this patient presenting with dyspnea or shortness of breath, what do you notice about this patient's vital signs? Is there anything that stands out to you in particular? Yes, a high systolic blood pressure coupled with a low diastolic blood pressure, which is known as a wide pulse pressure. This patient has wide pulse pressure. And what hypothesis, what do you normally associate wide pulse pressure with? Aortic regurgitation, exactly, aortic insufficiency. And so you look at the patient's hands and you look at their fingernail beds. And this is a movie that I'm playing for you here. And what do you notice here in the fingernail bed that you're specifically observing for because you have the idea or the hypothesis of aortic insufficiency in your mind? What do you notice about the fingernail beds here? Yes, there's Quincke's pulse, exactly. Does everybody appreciate that the nail beds are pulsating? Again, I hope that the video is playing as clearly as it is for me. There's an obvious pulsation there in the nail bed, and you have Quincke's pulse. And now you have a wide pulse pressure and Quincke's pulse, and now you really are thinking aortic insufficiency. What if I told you, and this patient presented with heart failure, had elevated jugular venous pressure, had orthopnea, paroxysmal nocturnal dyspnea, and has wide pulse pressure and Quincke's pulse on exam, and you're thinking aortic insufficiency. What if I told you that he did not have a diastolic murmur on exam, and the echocardiogram showed a completely normal aortic valve along with normal systolic function? So what are you thinking now? So no evidence of aortic insufficiency on the echocardiogram, which is a good study, good quality study. Well, it turns out that wide pulse pressure and Quincke's pulse are not specific for aortic regurgitation. They are simply findings of high output physiology or high output state. And Beto has identified arteriovenous fistula. And that is one of the answers to my next question for you guys, which is what are the causes of high output physiology, high output state? This patient now has a concern that there is high output heart failure in this patient. High output heart failure. What are the causes of high output heart failure? Fistula is one of them. Beriberi is another one. Sepsis, severe anemia. Exactly. Thyrotoxicosis, you guys are right on. Exactly. And now if you're thinking about, let's say, wet beriberi, if wet beriberi is on your differential, now again, what historical question might you go and ask the patient? What is a big risk factor for thiamine deficiency? Alcohol use. And in fact, you ask this patient about alcohol use, and he drinks 3 to 4 glasses of wine every day. So he consumes heavy amounts of alcohol. And indeed, you measure a thiamine level on this patient, and it is quite low, making the diagnosis of wet beriberi. First, he had a right heart cath procedure that demonstrated a cardiac output of 13 liters per minute, which is more than double normal. And so you've made the diagnosis of high output heart failure, and then you created some hypotheses from that. Could it be, severe anemia? Could it be thyrotoxicosis? Could it be wet beriberi? And those hypotheses led you to go back and ask the patient certain questions, look for certain physical findings, and send off certain laboratory tests. And that's why this is so important to understand what information you need to acquire and then acquire that information. Under normal circumstances, this patient would have been given the diagnosis of high output heart failure would have been given the diagnosis of heart failure with preserved systolic function, which is not an uncommon diagnosis. And he would have simply been given diuretics and sent home to be treated symptomatically. But recognizing the wide pulse pressure and the Quincke's pulse allowed us to make the diagnosis of high output heart failure via right heart catheterization, and then subsequently the diagnosis of wet beriberi. And that's why this is so important. Why is it so important to make the diagnosis of wet beriberi? Because it's curable. It's absolutely curable. And with alcohol cessation, so he stopped using alcohol and he was treated with thiamine replacement, you can see how his pulse pressure narrowed over time. So over the course of 28 weeks, his pulse pressure went from right around 100 down to around 60. And so this patient was cured. He no longer needed diuretics, no longer had heart failure. And how many clinicians would evaluate this patient and give him the diagnosis of heart failure with preserved systolic function and just given him diuretics and sent him home, versus how many clinicians would have noticed that wide pulse pressure, would have known to look at the fingernail bed and recognized the Quincke's pulse, and then put it all together to make the diagnosis of high output heart failure to cure this patient. That's why it's so important.